So, hello. I'm going to present you the work we did in Zurich. So, as you might know, spinal fusion after adult spinal deformity is a very frequently performed surgery, and one of the most common complications after this is proximal junctional kyphosis. And basically, the proximal junctional angle and the restoration is progressing with time, and the patient is coming back to a poor posture that brings disability and pain. So many risk factors has been highlighted already in the literature, but we would like to bring a new mechanism. So we think that the abdominal wall in preoperatively is just in a shortened position for years because of the deformities. Then the abdominal wall adapts to those deformities, and it becomes stiffer and shorter. Then postoperatively, the abdominal wall is stretched in the new alignment, then like this, and it puts the abdomen into tension, and it has to the extensor a lot of effort to counteract. Then patient would develop PJK because it allowed to decrease this unsustainable muscle effort and to decrease then the abdominal tension of the muscles. So finally, the objective of my study was to evaluate the effect of these adaptations on the trunk muscle effort required to maintain the postoperative alignment in patients who developed PJK versus the one that didn't develop PJK. So to answer this question, we had the database of the ESSG, and we took in this database 3 groups. So the no-complication group that didn't develop any mechanical complication, the mechanical complication group, so the other ones, and the PJK group, who developed PJK. And we analyzed 2 time points. So the post-op time points, so around 6 weeks after the surgery where the alignment is still good, and at follow-up where the groups with complication developed the complication, so a few months after. So then we built patient-specific musculoskeletal models with like patient-specific spinal alignments, and we evaluated the abdominal wall elongation in the model. And depending on this abdominal wall elongation from pre-op, we applied passive forces in the model that mimic the passive properties of the abdominal wall. And we applied those forces in the model, and we perform inverse static simulations to evaluate the muscle effort, so to estimate it in the model. And then we use this muscle effort to answer our question. So here you can see the muscle effort for the 3 groups and for the 2 alignments, so post-op and follow-up. So here what we can see first is that the patients with PJK has a more elevated muscle effort post-operatively than the other groups. That means that this alignment is actually more difficult to sustain for them than in the other groups. Also, we see that this alignment is reduced at follow-up and becomes similar to the no-complication group. So now we want to understand why it happens. So it's actually what we thought, but why it happens? So here you can see the abdominal wall length change. So first we see that the patients with PJK have the abdomen stretched post-operatively and way more than the other groups, significantly more than the no-complication group. And then we understand why the muscle effort was greater. That's because if the abdomen is more stretched, then the passive forces applied are greater, and then the muscle effort in the model increase as well. And then they reduce the tension by just like decreasing the abdominal wall length while developing PJK, and then it decreased the muscle effort as well, because it reduced those resistive forces. So we did also some correlation between the abdominal wall length change and the alignment parameters change. And we saw that actually the abdominal wall length was correlated with the change in pelvic tilt during the surgery, and not really with the lumbar lordosis. And when we can think about it, it means that it's actually not the lumbar lordosis that is corrected during the surgery that is acting on the abdominal wall length, but more the pelvic tilt, which is actually not modified during the surgery mostly. And that's because this pelvis has some reciprocal change to adapt to this new posture. And then these reciprocal changes are just acting on the abdomen and probably also the hamstrings, because it's probably the same mechanisms. And then, because they are really stiff, they are just pulling the pelvis to come back to the retroversion position. And then when you go back to the retroversion, then you just lose the balance in the sagittal plane. So finally, we had some limitations. So of course, we had an heterogeneous samples with various fusion constructs. We estimated the abdominal wall length because we can't see it on the radiograph, so it was in the model. And we did the assumption that tissues fully adapt to deformity, but we can't actually be sure that is the case. And what we need to remember is that the mechanism that I presented can be actually plausible and play a role. And those tissue adaptation would lead to PJK because of an increased muscle effort that is unsustainable, or because it increased the load at the proximal segment and create fracture. So more research are needed on the pelvic reciprocal change, and I think the goal is to limit the tension on those stabilizing tissues, and it would have implications for surgical planning and rehabilitation. Thank you very much.